Welcome, everyone. For those of you who are joining us for the first time, iCourse is a community of practice whose goal is to connect people who work in the social and behavioral sciences field of neglected tropical disease. Once a month, iCourse hosts a Knowledge Cafe webinar where we provide the opportunity for community members to present on a topic of their choice to a global and virtual audience. If you have any ideas for a Knowledge Cafe, please reach out to us at info.icords@gmail.com. And if you'd like to join as an iCourts member to stay up to date on our activities and events, please scan the QR code on the right side of the screen to sign up. Please feel free to introduce yourselves and type in any questions or comments you have during the session in the chat, and we will address them in the discussion portion of the session. Please note that this webinar is being recorded. To introduce the session, I will now pass it over to Dr. Allison Krentel, who is our co-moderator for this Knowledge Cafe, along with Dr. Ronaldo Schult. Over to you, Dr. Krentel.
Good morning, everyone. Good afternoon. My name is Allison Krentel, and it is a pleasure to be here with you this morning. And thank you so much for joining us for our webinar this morning called From Insight to Action, Leveraging the WHO Never Treatment Toolkit to Address Persistent Gaps in Coverage of Mass Drug Administration. So we have a really exciting lineup of speakers today that are going to introduce this concept of never treatment and to outline why it is important for our elimination efforts in neglected tropical diseases. We'll introduce the recently published WHO Toolkit to address never treatment, which is the result of a global cooperation to better understand this issue and how to address it. And we'll also hear firsthand how Guyana has been innovating to ensure that no one is left behind as it reaches the end game of lymphatic filariasis elimination. So it's my pleasure to introduce our speakers today. They have each been champions and leaders in this area. And they'll give their presentations, and then my colleague, Dr. Schulte from the Pan American Health Organization, will moderate our question and answer and discussion. So please, as our speakers are talking, put your questions in the chat, or feel free to put up your hand at the end during the discussion time. So our first speaker today is Dr. Jonathan King. He's a senior technical expert in the Malaria and Neglected Tropical Disease Department at WHO headquarters in Geneva. He's the technical lead for the Global Elimination Program for Lymphatic Filariasis, and his work emphasizes evidence-based guidance and strong collaboration with national health ministries, implementing partners, and academia. He'll be followed by Molly Brady, a global health consultant who supports global efforts to strengthen NTD programs. She focuses on improving data use, program quality, and strategies to reach underserved population. She works closely with countries and partners to translate evidence into practical tools that enhance equitable NTD delivery. And our final speaker today will be Dr. Annastacia Sampson. Dr. Sampson is a medical doctor and a public health professional with nearly a decade of experience in NTDs, focusing on lymphatic filariasis and leishmaniasis. She serves as Guyana's focal point for neglected infectious diseases and is the national coordinator for lymphatic filariasis, MDA, leading program coordination and community engagement. So it's a pleasure for me to pass the microphone over to Jonathan. Dr. King, the floor is yours.
Thanks, Allison, and good afternoon, everyone. Good afternoon from Geneva. Maybe it's morning time, maybe it's evening from where you're joining. As you know, preventive chemotherapy or mass drug administration is a priority strategy for controlling, stopping, interrupting transmission for several NTDs. And the effectiveness of MDA is ultimately what will determine whether or not we meet the elimination targets. Next slide, please. So we have several good drugs and combination treatment regimens for MDA. For example, we have IDA, we have moxidectin that's currently under review for WHO recommendation. These two regimens seem to have better, more prolonged efficacy of clearing microfilaria than standard regimens. But no matter how efficacious a new therapy may be, the effectiveness will always be less when it comes to program implementation. Next click, please. Oh, nope. Let's go back to the ladder and the square. There we go. Thank you. So there are multiple factors involved that may systematically miss or exclude groups within the community, which combined will decrease effectiveness. So all of these factors contribute to what we call as never treatment. Next slide. So when IDA first launched, there was extensive transmission modeling done, and that projected the impact of coverage and never treatment. And this was before we started using never treatment. We referred to this as systematic non-adherence. And you'll see that in the paper reference, but we refer to this as never treatment. So in the presence of never treatment, regardless of the overall effective coverage, we should expect more rounds of MDA to be required to reduce infection below thresholds. And that has huge resource implications for programs. Okay, final slide. Nope. Yeah, thank you. So why does never treatment matter? It's a major threat to achieving elimination. So never treated, that group of people may represent reservoirs of infection in the community. We know that more rounds will be required, and the presence of never treated also signifies that our NTD programs are not equally reaching all. And in fact, it may be an indication, and there are some links to other important public health interventions, and these never treated may also be missing vaccinations or bed net distribution. So it's important that we look at that. And thanks to PAHO, thanks to Dr. Allison, Molly, and many people who collaborated to develop this document. But this provides a means for programs to address never treatment. And doing so will enable better participation, potentially improve trust in MDA itself within the communities that are being targeted, and ultimately achieve the impact intended. So I'm going to hand over now to Molly to give us a quick overview of what you'll find in the toolkit. Thank you.
Thanks, Jonathan. Next slide, please. Yes, we just wanted to give a brief introduction to the toolkit. Next slide, please. And this toolkit was just published in December 2025. I think we'll be putting a link into the chat. But it had been under discussion in a series of core NTD research links meetings and other meetings. And the community had really come together to say there's a need to provide some guidance to program implementers to talk about why never treatment is important, how you might be able to identify it, and how you might be able to address it. So there was a group of experts, implementing partners, national program personnel that wrote the content of this toolkit, and then it was peer reviewed by over 10 different people from around the world. But while the toolkit was being created, different national programs were piloting the use of the indicator. So there were over 100 pre-task now epidemiological monitoring surveys for LF that have included it, and over 140 coverage evaluation surveys that have included this indicator. Next slide, please. And so the toolkit is 7 chapters, and it's really organized so that you don't have to read the whole thing from cover to cover, but you can pop in and look if you have a question for an answer to it. So We'll go into a little bit more details about these, but for example, if somebody's asking you why is never treatment an issue, why should we care about it, you could go to Chapter 1. If you're implementing a coverage evaluation survey and want to know what indicators you might be able to include, you could go to Chapter 2. If you're looking at ways of discussing with the immunization program how you can integrate things, you could go to Chapter 6. So it's very much designed to be modular and to be something that is used easily by different program implementers. Next slide, please. So looking a little bit into Chapter 1 and what that includes, this is where the toolkit talks about what never treatment is. It's defined as a self-reported state of never having consumed tablets during any round of MDA. And as Jonathan mentioned, there were a lot of different terms that had been used, but the community was really looking for one that was neutral and that would include both intentional reasons, like fear of side effects for missing MDA, or unintentional reasons, like community drug distributors have never come to my village, reasons for missing MDA. And here you can see on the right, this is the question, the main question for capturing information about never treatment. Including this year, how many times have you taken the medicines for, and then entering the NTD, whether it's LF or schistosomiasis, onchocerciasis, with the responses of never, one time, and two or more times. And this is because we found that, people might not be able to remember the exact number of times that they took MDA, but they do know whether they ever took it, and usually if they've taken it just one time. Next slide, please. So Jonathan also alluded to this idea of framing this issue of never treatment within the context of leaving no one behind. We want it to look like this middle picture here. Everybody has a clear view in this picture of seeing the football match, where we want everybody to have an equal opportunity to receive the drugs and to be protected from NTD infection. Next slide, please. So Chapter 2 is really the bulk of the toolkit. It walks through 4 different programmatic tools that are routinely used in NTD programs and talks about how to add NTD indicators onto them, and then how you might interpret the data that you get from those tools given their underlying sampling parameters and the potential for bias within each tool. It walks through a little bit of worked examples for each tool, what this might look like, and then begins to talk about how that information might be acted upon. But really, more of that information is included in Chapter 3. Next slide, please. So Chapter 3 has this decision tree that programs can use. They can take the data from those routine programmatic tools, that never treatment signal, and triangulate it with other data to determine what actions they need to do. A really important part of this is, are we seeing that never treatment is kind of similar across the survey area? Or are we seeing that it's concentrated in certain geographic locations or in certain demographic populations? All of this, as well as other considerations that might influence ongoing transmission, like high baseline prevalence or failures of previous surveys, can be used to try to determine where and how to prioritize actions. Next slide, please. And Chapter 4 lays out 4 different interventions that have been tested and proven to lower levels of never treatment. This is including never treatment into microplanning. This is a flow chart for community drug distributors that helps them when they're talking with people that they're giving drugs to identify if those people have been never treated, and then gives some short responses to the reasons in that area why people might have been never treated. The third intervention is training and motivational communication for CDDs and supervisors. This has a little bit higher of level of effort, but really is trying to help CDDs and supervisors know how to have productive conversations with people that might have been never treated. And then finally is a review of MDA registers in places where you might have multi-year registers to determine who has been never treated and then to engage those people and treat them. Next slide, please. So for each of these interventions, the toolkit contains information exactly what the intervention is, who might be using it, when it's implemented in the MDA cycle, what kind of training is required, and then what human resources or budgetary resources are needed, as well as links to additional resources about the intervention. Next slide, please. So Chapter 5 really walks through how you can develop and collect monitoring and evaluation data to see if your intervention worked. So it has questions about, did your implementation go as planned? And then was the implementation successful at lowering never treatment levels? And it takes an example from minors that had migrated into an implementation unit area and had been found to be never treated, and what kind of data you might be collecting and how in order to determine if that intervention was successful. Next slide, please. And Chapter 6 is a really important chapter to help programs think about how these activities could be integrated with other public health programs. So it looks first at identifying integration opportunities, and these could be opportunities to collect data on never treatment or to implement interventions to respond to areas or groups of people that are never treated. It then helps think through how you identify overlaps, whether that's with a malaria program, immunization program, HIV/AIDS. What are the target populations and the geographic reach of those campaigns or surveys? When are they implemented and what kind of funding do they have? And I think it's important to note here that immunization has something called the zero dose agenda, which is very similar to never treated, and that it's looking at children who have not had any immunizations. And in some places, those households might be the same as households that have been never treated for MDA, and there might be opportunities to do education and outreach together. And then finally, in this chapter, it's thinking through what kind of integration do you want to happen? Being realistic and flexible about what can happen given the time, and really the importance of super supportive leadership to making this happen. Next slide, please. So the 7th chapter is really a set of case studies from Nepal and Togo, Mali, Tanzania, and Guyana, looking how never treatment data has been used to improve a variety of NTD programs. Next slide, please. And finally, just to sum up, that we really want this to be a practical document, not one that sits on the shelf. We'd love your feedback to make sure that it's relevant to your needs. And I think Allison will discuss this a little more later, but we're open for more case studies and happy to hear from you. So thank you very much. I will now turn it over to Dr. Sampson to talk about the Guyana experience.
Hi, greetings, everyone. So I will address the innovations to address never treatment in the endgame of lymphatic filariasis elimination here in Guyana and share our experience with using the toolkit. Next slide. So Dr. King mentioned this when he was speaking. So we know that never treated persons within endemic communities for lymphatic filaria threatens the success of any lymphatic filaria mass drug administration campaign. And as he mentioned, they can prolong rounds of MDA in order for that country to reach elimination status. Now, subsequent to Guyana's completion of its debut IDA, MDA using the triple drug in 2021, an epidemiological monitoring survey was done. Next slide. So what we see coming out of that survey is that we had 3 communities across 2 regions that still was above that 1%, where we identified persons who were actively transmitting lymphatic filariae. In 2 of those communities, you will see, even though they're below that 1% coverage, they were flagged because unfortunately we could not find the persons to do the MF for. And you'll see the characteristics of these communities as to why they even fall in that bracket of never treatment and what were the consequences of these results. Next slide. Good. So before I go on to mention the characteristics, also in 2023, we had our first of 3 IDA impact surveys. So in that survey, it was done using geostatistical sampling. And in that survey, we would have tested or surveyed over 9,500 persons. And of that, we would have found 61 of them to be, or 64 of them to be reactive to the filarial rapid test, or the FTS. And we were able to do of that 61, 54 microfilaria tests. So, and all of the results was negative, sorry. We did not find anyone during our IIS that was testing positive for filaria. Huge accomplishment for Guyana in its progress to eliminate filaria as a public health issue. However, what happened, even though that was supposed to be the decision rule as to if we stop MD or not, we had to proceed with caution. We had to remember our 2021 results of the EMS. What were the characteristics of those persons who were testing or who had a FTS positive results? We find that most of them were men, 63% of them were men. And the other highlighted characteristic there is that approximately 30% of them were classified as never treated. 29% of them during the EMS, and then we had a 31% of them in IIS. So because of this here, we had to now pause and reevaluate how we're going to go forward, because yes, we passed the IIS, but we had to proceed with caution to ensure that we give equal opportunity to those persons who we're finding that are positive but were never treated. Next slide. So what was the intervention, or what did we do in order to ensure that we were addressing those persons who were never treated? In 2024, we had a workshop right here in Georgetown, Guyana, the first of its kind, to actually address and focus more targeted, target 3 areas of interest, as you saw in the EMS results. Those were Parfait, Lodge, and All Boys Town. Next slide. Good. So coming out of that workshop were these 3 key findings. The main reasons that you have persons being never treated is because they're refusing. Why are they refusing? These are the reasons. Some of them because of safety concerns surrounding how safe is the filaria pill. In addition to that, you have persons who claimed that they were not aware of the filaria, of filaria and even the campaign. So there was a general lack of awareness regarding the purpose and the importance of persons actually participating in the filaria campaign. And lastly, we saw that a lot of misinformation would have played a part in persons refusing. Of course, that's misinformation regarding the pills and the disease itself. Because, for example, quickly, one of the example of misinformation is simply how does someone get filaria? So you have persons who don't believe that it's a vector-borne disease. You have persons who believe for superstitious reasons. That's why, I have a swollen lower extremity, for example. So those are some of the misinformation that you deal with when it comes to refusing the MDA pills and persons not being treated. how did we deal with these key areas of refusal that led to never treatment? Next slide. Great. So coming out of that, based on what we saw were the three key reasons for a refusal, we came up with a list of 10 recommendations because based on the EMS results, Guyana was now planning to have 2 rounds of MDA in the key areas or in the 2 regions where we've had persons from the various communities testing positive for filaria. So we came up with 10 recommendations, and we were able to include or adapt 7 out of those 10 recommendations in our MDA that we had done in 2024. All right, so huge accomplishment. We had 10, we were able to implement 7. Unfortunately, we couldn't do 3 of them because of different reason. One of the most important reason being the time between implementation and actually having or being able to implement the other 3. So one of the main one, increase the number of pill distributors and supervisors in those 3 hotspot areas, among others that you can see there present. Next slide. How did the intervention or the recommendations help us? So as you can see here, this was the coverage that we would have achieved during our MDA in 2024, and it shows or it highlights the coverage of the 3 key areas and then region 4 as a whole. So we had the All Boys Town and Lodge, they would have achieved 74% of their target population that was covered. And we also had Perfect Harmony achieving 76%, of their target population that was covered. Now, Region 4, however, they achieved a 65.7% coverage, as you can see there. Still not where we wanted it to be. Nevertheless, we find that our 3 key areas of interest would have achieved significantly over that 65% threshold. What were some of the recommendations that were, or what was next after this? We would have had the workshop, followed the recommendations or implemented the recommendations, implemented MDA. These are the results. What was next? Next slide, please. So there were ongoing concern about never treatment. And like I said, especially in our 3 key areas, because like we saw before, these were the areas we actually found persons who were positive for filaria. So what did we do? We had, because this was in preparation for our 2025 MDA, we had new consultations with program personnel, frontline workers, community health workers to understand more what were the barriers that continued to lead to people refusing the filaria pills. And these are some of the 2 main points that we saw coming out there. Men, again, we saw men coming up as the group or the geographic that continues to refuse. And then the Rastafarians for religious reasons who sometimes don't believe in using medication that are what should I say, that are made, but they prefer to use, the local stuff and their traditional medicine, so to speak. So what was next, or what could we do different going into a 2025 MDA as it comes to never treated persons? Next slide. So there was an innovative new strategy, which we were really excited about when we heard about it. And of course, willing to give it a try, because we want, at the end of the day, when Guyana stops MDA, we can say that everyone had the opportunity to take the filaria pills. We don't want to leave anyone behind. We want to make sure that everyone had that opportunity. So we were really excited about this new innovative strategy, engage and treat and the test and treat. So it was adapted from a study done in Ghana. We had WHO would have provided the rapid test or the FTS for the use in the three areas. So this innovative strategy did not go for all the entire region 3 and the entire region 4. No, it was specifically focused on our three key areas where we were finding persons who were testing positive. So we had a flow chart that was developed with the help of Dr. Krentel and her team, a flow chart that was developed to identify a pathway from the pill distributors, who are usually the first persons the population engage with at the community level. So you had that flow chart of how things occur from pill distributor until it channels up or goes up the hierarchy to the supervisors. It provided an opportunity for us to understand a bit more in detail why people will refuse treatment that are offered during MDA. Next slide. So this is the flow chart. So we have where our pill distributors would record the refusal and report the names and contact information to their supervisor. So if I can quickly run you through this. So as a pill distributor, I show up to your home, you refuse to take the filaria pills. I take your name, I take your address, and I take your contact number, and then I channel that to my national supervisor, who is his or her task now to go to your home and engage you. Sir, ma'am, why did you refuse the filaria pills? Oh, I refused the filaria pills because I don't think I need to take it after taking it for 2-3 years before. I don't think this year I should take it. So you, as a supervisor, you're able to, or you should be able to convince that person and explain to them why is it that they have to take the pills again, even though they would have taken it 2-3 times before. Sir, ma'am, you have to take it because you're still in a community where persons are actively transmitting. And as long as you have active transmission occurring, you're expected to continue taking your pills. If that doesn't work and you continue to, or you stand by your refusal, then the next thing the supervisor does is ask, would you like to have a filaria rapid test done so that we can, know for sure that you're okay or you're good? So that person is now offered a FTS test. If the results is negative, then we're okay, you don't have the disease, fine, you don't want to take the pills. But if it's positive, that person is definitely encouraged to take the ID. In a nutshell, that's how the whole flow chart work from beginning to end when dealing with those persons. Next slide. Good. So coming out of that engage and treat, test and treat, these are the results quickly for the three key areas. So we had persons who would have refused or met. We had 100 in perfect harmony, 100%. So everyone who would have refused were met by the supervisor. In Lodge, we had just 41% of the persons being met, and All Boys Town, 67% of persons being met. In perfect harmony, we did not meet with anyone who refused, while in All Boys Town, 33% of them did. Interestingly, an additional 83 members, were treated in perfect harmony. So for every household that was visited that persons refused, when they were able to convince one person in the household, you find that other persons in the household decided to also take their pills. So in total for perfect, you had 131 persons being treated coming out of that engage and treat, test and treat innovation. While in Lodge, we had just 4 additional persons. In Lodge, we had 1 person who wanted to be tested, and in All Boys Town, 6 persons. Interesting to note is that of the persons that required a test, they were all negative. Next slide, please. So what were the reasons for refusal? And if we can look here, we see that fear of side effects took the top of the chart. persons are refusing to take the filaria pills because they're afraid of what the side effects or what side effects they may experience. Followed by pill distributors who never came, persons who, claim who use alcohol and don't want to mix alcohol with taking the filaria pills. And we had 6% of persons who claim they're not at risk for the disease. So reasons for your refusal there. Also, you had persons who were told that it's the last year and they don't need to take it again, and hence their refusal, and persons who say it's their right to refuse, so that's the reason for their refusal. Next slide. Good. So in all, we see that it's this innovative toolkit, engage and treat, test and treat. It's a very feasible strategy. At least for us here in Guyana, it was really feasible. We incorporated the strategy, as you can see, and as I mentioned, during MDA implementation period. So there's no additional cost to the program. So if you're thinking it might be costly to get it done, no. If you're having an MDA, you incorporate it right within the scope of your MDA, so you don't have to think about that additional cost it will do to do it independently. Refusal logs were easy for the PDs to use, and it was an idea adopted from the immunization program at the Ministry of Health, who would have used similar approach. So we find that we don't need to go reinvent the wheel. We can always use what we already have and adapt it to what we want to get out of it. So the PDs had the refusal log where they would have put the necessary information. So the use of tests, not many were needed. We had a donation of 300 kits, and we only used 6 of them, if I remember correctly. So what we will do with the surplus is that we have our IIS2 coming up in the third quarter of this year. So the surplus will be used there. So you don't have to worry about having resources that will expire on your hand because you didn't get to use it. You can always look at it that way, that it can be used to do another activity that you may have. Important also, no additional human resource personnel is needed to do the test. We would have trained persons that were trained since IIS1. They also have the necessary skill set, and were able to do that without any issues. So you don't really necessarily need to employ additional persons in getting this done. Next slide. And lastly, Guyana has been highly committed to address never treatment in lymphatic filaria elimination endgame, because we understand the importance of ensuring that you capture and you include and you treat your never treated, because like I mentioned in the beginning, they can put your elimination journey at risk if they continue to be never treated. So it's really important that we address whatever those issues are. Addressing never treatment needs an approach that is flexible and adaptive to new realities within the different communities. Of course, it may not be a one-size-fits-all for the different regions, but you can see what works for you and always be willing to flex it to suit your situation. And community and frontline health worker consultation is crucial in understanding which innovation will work and will not work. Look, we don't sit at the program here and decide that we're going to dictate what happens in a community. We have to get the community involved because they're the ones with the experience. They're the ones with the knowledge of their community. So of course, you have to bring your stakeholders on board to understand what are the characteristics of the community that you're dealing with, so you can tailor your plan and your implementation to suit that, so you can have maximum outcome and of course a successful outcome. So all in all, we were in Guyana here, we were grateful for this additional toolkit that is going to help us significantly towards our journey to eliminate lymphatic filaria as a public health problem, and we are so close to getting that done. So we're grateful. Thank you so much for having me.
Thank you so much, Dr. Sampson, and to all our speakers. It was just great to hear the experiences, and certainly the experiences from Guyana. So thanks very much. I'm going to pass over to Dr. Schulte, who is the regional NTD specialist at PAHO, and he will be moderating our Q&A and discussion. We've got just under 20 minutes for that. Just as a note, between Ronaldo and myself, we can accept questions in the chat in Portuguese, Spanish, or French. So if English is not your first language, please feel free to write those into the chat, and we'll do our best to translate them for speakers. However, the response would be in English. So I'll pass over to you, and thanks again to all our speakers.
Thank you, Alison. Thank you very much for the presenters. Amazing presentations we saw today on about this toolkit, which is very, very important for all the programs that use MDA as a strategy. So we have a couple of questions at the chat that it was already answered, but we still have more. And again, as Alison mentioned, we're welcome to receive all your questions. Well, we have a question here. I will ask Dr. Jonathan King about can the toolkit be used for other entities apart from LF?
Absolutely. It's not designed just for LF. The reason that LF was highlighted here is we have some examples where people have already incorporated this, but definitely for onco, for trachoma, for soil transmitted helminths, for schistosomiasis, for where preventive chemotherapy is used, this is going to play a factor. So programs need to incorporate ways to address never treatment, to investigate, to find out where it's happening, the extent, and then go through the toolkit to identify some methods to address it.
Thank you, Jonathan. Well, Molly, how does the toolkit address the issues of misconceptions, stigma, and discrimination that fuels the cycle of LF?
Thanks, Ronaldo. I think one of the places in the toolkit that you can find more information about that is the chapter 4 on the different interventions. Particularly, I'm thinking about the motivational communication and working with training the CDDs and the supervisors so that they can respond to those issues when people have fears or misconceptions about that. I think it's those issues tend to be very context specific. So it's really, as Dr. Sampson said, working with the community and the frontline health workers to understand what those are in your community and then crafting those messages to respond to them.
Thank you, Molly. And I think this one is for you too, but feel free to jump in, Jonathan, if you need. Has the toolkit dealt with vector data or their sample collection?
It does not. It's solely looking at MDA, but I'll let Jonathan talk about other kind of vector resources.
Yeah, because right now vector control is not a priority intervention for these diseases. MDA is the priority strategy, and there's scientific reasoning behind that. But this toolkit is specifically looking around how do we maximize compliance with the effective interventions, the effective MDA interventions we have.
Thank you. And we have a question here for Dr. Sampson. Are the drugs made available at primary health care or only during MDA?
So the drugs are available at the primary healthcare level during the MDA period. Outside of the MDA period, it's not accessible at the primary healthcare facilities. And those I refer to are your health centers.
Thank you. Thank you, Dr. Sampson. And here another question for Molly and Jonathan. Has the toolkit addressed the drug delivery channels?
I don't think it explicitly talks about drug delivery channels, whether that's house to house or schools or fixed posts. There are other WHO materials that talk about that implementation of MDA. Jonathan, do you want to say anything more about that?
Yeah, I think as programs address never treated, you have to look at your delivery strategy and whether or not this is the right one. And these are some of the things you can learn as you get down into which populations are being missed. Is it because of the delivery strategy? So that does play a part in the investigation.
Great, thank you. And another question for Dr. Sampson. How does the toolkit create community trust and social behavior change?
Excellent question. How does it contribute to community trust and behavioral changes? So as I mentioned, we don't sit at a program level at the Ministry of Health and dictate this is what is going to happen in Parfait, Harmony, or All Boys Town or Lodge. What we do is we engage the community. We bring people who live in the community to our meetings or to our workshops. We bring whether it be a doctor at the health center, a resident or a person from the community with filaria, one probably without filaria, influencers in the community, who have that reach the person. So we involve the community and we get feedback from them. What is the issue? Why are you refusing? So their involvement is them having trust in us, because we could have stayed and say, hey, this is what goes on there. But no, we're involving you because we want to know how best we can help your community move from this status whereby they're positive cases to where we're below that threshold. So, and in addition to that, I think with behavioral changes, it deals a lot with educating them. So during those workshops, it was a perfect opportunity to also engage them and help them to understand basic things like what causes filaria, which a lot of persons have misconception about. So educating them on the disease itself can also influence them to have behavioral changes, positive behavioral changes.
Thank you, Dr. Sampson. We have two more questions here for Dr. Sampson. In the ENT model, do you think a negative FTS is sufficient to stop efforts towards convincing those who refuse MDA or who are never treated?
So yeah, I mean, at the end of the day, why are we even given the pills? At the end of the day, the pills are being given so that we can eliminate the disease, and for those areas where we implementing that, when we test again or we do our IIS or EMS, they're below that 1%. So my purpose is to give you the pills. So if you don't take the pills and I offer you a test and I see that it's non-reactive or it's negative, I'm comfortable that I know this person does not have it. Of course, we make every effort to, even after that, still encourage you to take it. But with a negative FTS, that's good enough for us, because we know that, the pills are doing what it has to do.
Thank you, Dr. Sampson. Another one for you. Beyond the reasons why people were never treated, did Guyana explore other factors like social, demographic, economic that could have influenced the never treated?
So yeah, and I think that also came out in the presentation, because we identified specifically it was men who were refusing, Rastafarians who were refusing, and also these three communities, especially the Lodge and All Boys Town, they're in central Georgetown, and Parfait Harmonies in Region 3, which is a little distance outside of Georgetown, not too far. So what we find, especially with the two in Georgetown, is that yes, they're moderately impoverished communities. So therein in itself lies the reason that you will have the issues you're having when it comes to this. And it's not only for MDA, it's almost for all health interventions. These are the common characteristics you're finding when it comes to health interventions, whether it be immunization, MDA. So it's a common trend that we're seeing, but to answer the question, yes, we would have explored what were the other factors, and it did come out in my presentation. We had men, Rastafarians, those group of people who were consistently, refusing the filaria pills.
Thank you. We have here a question with, well, it's 3 questions in one. I will start with the first one. Dr. Sampson, how were the barriers responsible for this refuse were addressed?
Great. So if you notice in my list of recommendations, we had, for example, so let me go back. Refusals, we had 3 main ones: misinformation, lack of awareness, and the other one was fear of the medication. So what we did for our 2025 campaign is that we would have hired a social mobilization consultant. I mean, we do it every year in preparation for our MDA, and they're responsible for preparing direct messages. So it's like a feedback answer. This is my problem, misinformation. I don't know what is failure. I don't know what causes it. So what we did through that consultant is prepare messages tailored to combat misinformation. And it's not just messaging in the news and newspaper. So we also, the message was tailored to capture the audience. We know everybody's on Facebook or TikTok, so we use those medium also to put our messages out there. So you had information being shared in the form of a skit, in the form of songs, different jingles, different ways that you would have used to combat, for example, misinformation. Similarly, with the fear of the side effects, you had different messaging, so to speak, that was placed out there to combat what we noticed were the issues or difficulties coming out of why persons were never treated.
Thank you. And this question, I believe it's regarding to the test and treat. Are the RDTs facility? Are the RDTs facility based or community based?
Oh, if it's in the facility or if it's in the community, is that the
Yes.
question?
Yes.
So thank you for the question. So the RDTs are at the facility level. However, in the case that it's needed, it's given on a needs basis. So for example, when we did the engage and treat, the persons in all boys town, we had a few of them who are requesting the test and treat. So that information is then passed from the supervisor to myself, who will then instruct the laboratory persons to, this is the area you need to go take 5 FTS, for example, and test the persons.
Thank you. And this question, I would like first to hear from Dr. Sampson, and then I would like to hear the point of view from Jonathan and Molly. What are the learnings and how does this approach contribute to a cost-effective MDA, the test and treat?
The learnings from the test and treat, really good question. So one of the things we learned, and it came out mostly from the Parfait Harmony test and treat, engage and treat, test and treat, is that a lot of persons were more willing to, because your supervisors, your supervisors are persons who are maybe a nurse, a doctor, a medic, someone in the health facility, while your pill distributors are not necessarily all healthcare personnel. There might be some teachers included here. So what we find is that when the supervisors go to the homes of those persons who are refusing, the persons who are more inclined to hear the filarium messaging from them than to hear it from the pill distributor. So that's one of the major things that we would have learned coming out of this. It all has to do with who is bringing the message to me. Do I want to trust a teacher to treat me? Or am I going to take it from a nurse or a medics, someone who knows about it? So that's one of the things I want to mention there. Cost effectiveness. As I mentioned, we would have done this within the scope of our MDA. So it was not done independently where you need to go have a separate budget to deal with that, so to speak. It all falls or came under the task that the supervisors were expected to do during the scope of the MDA, and they would have been reimbursed accordingly under that umbrella of MDA, and not necessarily have MDA and engage and treat and test and treat separately. So that is one way you can ensure that it's, remains cost effective.
Go ahead, Jonathan.
First, Dr. Sampson, this is really great. And it's a really amazing work and pioneering work that you're doing, because this is relatively new and this toolkit is new. Yeah. So thank you for sharing your experience with us. I'll encourage among the collaborators here to help look at this cost question. I do want to make the emphasis that, your program in Guyana is advanced, and you guys, out of the 10 regions, you've narrowed down with the epidemiological surveys that these were your last, remaining sites. Yeah. And I think this is where it's a setting, it's almost sub-implementation unit when you have a few areas remaining, that we then explore this engage, test, and treat as a strategy. I'm not sure that engage, test, and treat would just fit into any program, right? Especially if there hasn't been a lot of MDA in progress already. So I think that is something that we need to explore further. And we can ask. I think I saw Dr. D'Souza online, and he was, a lead researcher in one of the papers that you referenced. How did he feel about that? And I think you did the research in Ghana. If he's still online, maybe we open to him as well.
Molly, any comments about the test and treat strategy? Good. Well, we already are beyond our Q&A session. Alison, I give the floor back to you. Thank you very much.
Jonathan, you had one more thing. I'm seeing Jonathan.
Yeah, I think that there's tools that we can use across every level right now in the programs. And if I'm sitting at the national level, I can make a decision to ask questions about never treatment in any type of survey for any of the PC NTDs that goes out. I think that's a big first step. And then, I think then the value and the use goes down to the district level of, how do we engage the reasons for never treatment. And we need to be aware that even if you have effective coverage, you may still be missing a section of the community that will serve as the reservoirs. And so if you're not seeing epidemiological progress in an area, but you're getting high reported coverage, that to me is a red flag. And I think you could be able to use some of these tools to dive down deeper and look for never treated. But thank you. Sorry.
You get the final word. No, that's great. Thank you so much. And just a huge thank you to all our speakers and to Ronaldo, and to everyone who put questions in the box. I know there's a few of them, quite a few that we didn't get to. So I've noted them down, and this whole month, we're sort of focusing on Never Treatment. So there'll be opportunities perhaps to visit the ICORD's discussion board and engage a little bit more with some of those questions that we were unable to answer today. So before I hand back to Varsa, just to wrap us up from the ICORD's perspective, what we want to do, and you've heard the example of Guyana, and as Jonathan mentioned, programs are going to be addressing this in different ways. You might be just introducing the indicator into a regular survey, or you might have noticed a red flag and you want to think about how to address it. We want to engage your interest in a focus area on Never Treatment that would be sitting here at ICORDS. And ICORDS sort of hosted this initial focus area out of which the toolkit kind of was born. And so we want to capture, provide an opportunity for people to meet together, to share their experiences, to capture your experiences using the toolkit. Also to get new case studies. As Molly mentioned, we've got a good list of case studies within the toolkit, but as researchers and programs and implementing partners continue to use this indicator, it's an opportunity for us to continue to collect case studies on your experiences. So if this is something that you would be interested in joining, please fill out this form. There will also be another webinar through GONE in a couple months' time focused on Never Treatment in settings where there's onchocerciasis transmission, and so looking at that as well. So we'll continue to solicit your engagement in this area, and just look forward to seeing how this can be used and how different flexible and adaptive approaches are going to be coming out of programs as you continue to address this issue. So a final thank you to Jonathan, to Molly, to Dr. Sampson and Ronaldo for your time today. And thank you to everyone who joined. And I will pass over to Varsa, who will just quickly launch our survey. So thanks, everyone.
All right. Thank you so much to Dr. Jonathan King, Molly Brady, and Dr. Annastacia Sampson for speaking at our session today. And thank you to Dr. Alison Krentel and Dr. Ronaldo Schulte for moderating as well. If you would like to attend more knowledge cafes like this, stay up to date on our activities by scanning the QR codes linking to our website and social media as seen on the screen. We also have listed a couple of exciting new activities coming up. We will be launching applications for the hiring of our regional ICORDS manager next Monday on the 23rd. And we will also be seeking requests for proposals for the formation of ICORDS University subchapters in the near future. So please stay tuned for more details. Thank you all for attending, and if you haven't already, please take a moment to fill out the Zoom poll before you leave. I will be launching it in a few seconds. And thank you again, and have a great day, everyone.